everyone. It's Wednesday night. I believe we're live. And I'm going to tag the topic for tonight, which is basically fibroids, but more so focusing on the fact that fibroids, they return after fibroid surgery, which can be quite a devastating and almost, you've done this surgery, you dealt with your fibroids, and they can return. So they can grow back. And that's what I'm going to talk about tonight. But obviously, as we talk about fibroids coming back, I'm going to be addressing them on the whole. I did do a pretty involved series of lives about fibroids last year. So I think it's time for a refresher. So welcome on in, everyone. I hope today wasn't too wet or rainy wherever you are. And thanks for joining me on this Wednesday night. So fibroids can go back is the topic of the evening. And welcome on in. Hi, everyone. So, first of all, just to refresh you guys, if you've been coming to these lives, hi, Emily. I talk about fibroids quite a bit in the office, and they are the most common benign tumor that grows in the woman's body, and it grows in the uterus in the womb. It occurs in about 80% of women. That's the numbers we've arrived at. When I first entered medical school about maybe 2 or 3 years ago, the fibroid rate was estimated to be 50% of women suffered from them, and now we're up to about 80% of women. And I have some new updates on the information for us tonight as well regarding fibroids. So fibroids really occur in women before the age 50 during the reproductive years because of hormonal effects. And there are some very common symptoms to indicate that you may not only have fibroids, but fibroids that are increasing in size, increasing in number, and becoming more problematic as well, too. So pelvic pain, pelvic pressure, painful periods, very crampy periods, vomiting with your periods, and out of this world severe PMS, kind of the classic grouping of symptoms with fibroids. And most of the times, these symptoms tend to be occurring around the time of your period, but the pelvic pressure, the increase in your abdominal size because of fibroid growth can occur throughout any part of the month. But that is in a nutshell most of the symptoms. So of course, you guys know I've been doing these slides. So here I depict some of the symptoms in this cartoon. And of course, as I talked about abdominal growth of abdominal size, we did a cute post maybe about 2 weeks ago about the fupa, right? The fat over the vagina area. And sometimes that's an indication in a thinner woman that has this bulge that there might be a fibroid growing there. Other symptoms include increased need to urinate or frequent urination or difficulty being able to hold your urine over time at a young age. And that's simply because of the anatomy of the pelvis, where the bladder tends to sit right in front of the womb. And if the womb is enlarged and heavy with fibroids, there's not enough room for the bladder to fill. And you pee more frequently. Painful intercourse is another symptom of fibroids as well. Lower back pain, chronic back pain, constipation. Again, they are very annoying because they can be located in several different areas in the womb. And constipation is one of the less thought of symptoms with fibroids, but yes, it can occur. And just increased vaginal discharge, which tends to be the issue if fibroids are located within the cavity of the uterus as well. So just kind of giving a bit of a refresher about the symptoms, because it's important to identify these, because if you're talking surgery for fibroids, then we have to have a reason for that, right? Surgery comes with a lot of risk and decisions and cost and consequences also that might be quite long term. So if you run through these symptoms, these are not all, obviously, anemia, heavy blood loss. The basic ones that everyone has with fibroids really is the abdominal pain and cramping and bad periods. But you may not need surgery if your fibroids do not bother you. You may consider surgery if these symptoms are becoming quite problematic, especially more so with heavy menstrual bleeding. Bleeding in between periods starts to happen as fibroids continue to grow in size and disturb the uterine wall. Pain or pressure that becomes unbearable in the lower abdominal area. and of course the urine and the bladder issues as well. Surgery might also be an option if you want to get pregnant, or at least reserve the option to have a pregnancy in the future, because sometimes fibroids can increase risk of pregnancy or cause infertility as well too, cause miscarriages and complications during your pregnancy. They can again be very pesky parasites that can affect you in this way. So that's, in terms of making a decision for surgery. Now, in general, if we're talking surgery for fibroids, we're talking either removing the fibroids, which is called a myomectomy, or removing the entire uterus, which is called a hysterectomy. Surgery can relieve the fibroid symptoms that I just talked about, and it still depends on the individual, what your symptoms are, and what you hope to gain by doing fibroid surgery. Right? So you'd have to kind of talk to a professional and look at your own individual findings as to how many fibroids, where they're located, and again, the symptoms are a huge part of that decision-making process, because the risk you take for surgery, your symptoms must be debilitating enough to warrant taking that risk, right? And then you can make your decision based on that. So I just talked about the types of fibroid surgery and the type of fibroid surgery that you're going to have to consider. Again, the size of the fibroids would impact the approach, whether you need an abdominal incision, whether it could be done laparoscopically or not, and then the number of fibroids you have in the uterus, where they're located in the uterus, whether you want to have children. So the different types of fibroids, right? They are these benign, non-cancerous growths that happen in about 80% of women. I found some data actually today from the UK. The NHS in the UK actually finally came out and announced that fibroids are thought to develop most frequently in women of African Caribbean origin, right? Now that we've actually said it out loud that this is who it happens to, hopefully this will lead into more studies to figure out why these tumors occur. But the UK did make a clear statement that it is mostly found in African Caribbean women. And now we have to look at not just our ethnicity and our genetics, but also our environment and our healthy lifestyle or not unhealthy lifestyle, food choices, and so forth. Now, these are different locations where we can find fibroids. And for as long as I've been doing this, I'm usually still surprised sometimes by the number of fibroids that could be contained in one uterus. And that's why the symptoms may vary. You can have fibroids located on outer areas of the uterus attached by a stalk. They can grow into the wall itself of the uterus. They can hang into the cavity and prevent pregnancy. So the location of the fibroids do sort of affect the symptoms that you may experience, right? So this is another key factor when you're making your choice for surgery. Like in this picture, that large fibroid that sits at the top of the uterus, that fibroid is not typically going to cause significant, these periods will be heavy, right? But that specific one has room to grow. And that's the one that can grow outside of the womb and even get to the size of a watermelon, size of a papaya. They can get fairly large because they continue to grow due to hormonal influences in women of reproductive age. The pedunculated one in the middle, that would prevent a pregnancy, and that woman may need a fibroid surgery to be able to conceive or to prevent her from having continuous miscarriages as well too, right? So and keep that in mind. A very large size womb, like that fibroid that you see to the top, a very large size fibroid can compress the large veins in the pelvis that run from our heart down to our legs and cause blood clots in roughly about 4% of women with fibroids that size. A fibroid that size that sits at the top that continues to grow and gets to the size of a watermelon can also compress the kidneys on either side and affect kidney function. Another rare one that can happen, that little one that's sitting in the middle of the cavity can start growing down into the cervix and actually prolapse through the cervix. Very painful experience for this woman, and it can cause infection and severe bleeding as well too, right? So this is actually a picture of my hand. This was surgery. I probably did this surgery maybe about 2 years back. And this surgery itself, this is the womb before we actually began the procedure. And this is my hand just holding on to one of these fibroids. I believe, if I remember correctly, with this specific procedure, we got 12 fibroids out. And when we do these surgeries, again, it's always a surprise, because the ultrasound, the MRI, CAT scan is terrible for fibroids, but ultrasound and MRI still can't really tell us the sheer number of fibroids until we get in there. And this is important to understand, because your doctor might be I might be telling you that we see 5, and I get into surgery, this is my hand holding on to one of the ones I would have seen on ultrasound, but sometimes we have 12, 15, 18, 20 fibroids coming out in one surgery. And it's quite a unexpected situation, but not that shocking for us, because that's what we see, but unexpected for the patient to wake up from surgery finding out that, oh, my ultrasound said 4 fibroids, but they removed 22. And it's just very difficult to visualize the much smaller ones that might be located and embedded in the wall of the uterus, or hidden by the larger fibroids. And the issues here really carry through past surgery, because in this procedure we remove 12 fibroids. In this procedure I would have 12 times cut into the womb, remove the fibroid, repair the wall of the uterus, and then we hope that the healing process allows this woman to have a successful pregnancy. But as you can well imagine, her story is not ended there. She has to get pregnant, remain pregnant, and then deliver. So after removing all of these fibroids from the uterus, you always have to consider the fact that you may end up with a cesarean section. So when you decide on doing surgery for fibroids, you have to consider another surgery down the line for your baby to be born, right? If the point of surgery is to reserve and preserve the ability to carry pregnancy, most times we may have to consider the fact that there's going to be a cesarean at the end of it all as well too. Your surgical decision, again, depending on symptoms and your pregnancy goals, really would be based around your specific findings on ultrasound or MRI. Right? If anyone has any questions, feel free to ask. But that was, again, a surgery that I did. I have a bunch of these pictures in my phone. And sometimes we have like a tray of fibroids laid out, because it's sometimes quite a lot of them that may occur in one uterus. Now, in terms of pregnancy and fibroids, a lot of times we would consider doing surgery before getting pregnant, because being pregnant with fibroids has its own unique set of complications. Getting pregnant and having fibroids is usually not an issue. I just said about 80% of women have fibroids. The NHS in the UK just came out and said that Afro-Caribbean women have it the most. But it doesn't prevent all of us from having children. Again, it's case by case, and some women will conceive and have multiple pregnancies without needing to do fibroid surgery, and on the other hand, someone else will not get pregnant or must have surgery to get pregnant because of the sheer number of fibroids or the location of the fibroids. Now, in terms of the risk of pregnancy with fibroids are responsive to hormones, specifically estrogen hormone. We don't know what causes them. We know women of specific ethnicities get them more, but all women, whether you're white, Asian, any race can get them, but we see it more in women of African ethnicity. But now the numbers are about 80 to 90% of women have them. So childbearing is not impacted by fibroids in 80 to 90% of women, but in those who are having difficulty, we may consider doing surgery. And that surgery is called a myomectomy, which is a surgery to remove the fibroids and keep your uterus. Now, it does relieve symptoms. So even if you don't have specific pregnancy goals, you may consider the myomectomy just to live a better quality of life, right? And then reserve the option for childbearing later on. This live tonight is very important, because that one statement about preserving the option also means that there's a time frame within which you should make your pregnancy goals happen as well too, after doing fibroid surgery, and that's typically a 5-year window. If you do your surgery in 2022, I'm literally going to tell you should really make an effort. Now, I don't provide partners and I don't provide, those type of services. But seriously, if a fibroid surgery is done and we're looking at the studies, we know that there's a 5-year window before fibroids can reoccur. Now, they don't grow back, let's be technical for a minute. If they've been removed, those fibroids are not coming back, but you're sort of genetically programmed to produce them. So you produce more, new ones return, more so to be specific. And that tends to happen within a 5-year window, right? So we have a question from Bruno Ali Mars. That's cute. Can this disappear with herbs? Is birth control the only way to control them? So I'm going to touch on those things as we talk, but they don't disappear with herbs. Thank you for your question. If that was the case, I would just do a live and list all the herbs to do for for controlling fibroids. So there's no studies yet that show there's herbs to make them disappear. I never say never. And I have experienced many different strange things, and I have seen herbal medication do some really miraculous things. But again, which herbs, how much to take, what dose works for you, not there yet at all, unfortunately, right, Miss Bruno? Now, the other question about the birth control pill, it's not the only option to control them. It's used to control the symptoms. So birth control pills don't actually shrink or remove fibroids. The birth control pill is actually just geared towards you controlling the symptoms that I alluded to before. The heavy periods, the anemia, the severe cramps, the severe pain, those would be addressed more so with the pill, use of the pill. But in terms of herbs, this would be an easy fix, right? If 80% of women in the Caribbean suffer from these fibroids, then we should by now know which herbs would work best for them. So unfortunately, that answer remains unknown at this point. We have another question. Shanna, hi Shanna. Not disappear, but maybe shrink with herbs. So again, I hope I'm getting you guys clear on that one. I don't have a list of herbs to shrink fibroids. If I did, I would lead with that for sure. If I did, a lot of us gynaes would probably be more herbalists than surgeons as well too. Dietary changes is the next question. What about that? Absolutely. They have identified red meat, specifically ham, right? Salted ham as a no-no for women with fibroids. Bear, don't kill me. Sorry, ladies, but bear is another no-no. And I'm going to touch on a list of things that you should be doing. What we do know works in terms of dietary changes is high fiber in your nutrition. High fiber nutrition definitely tends to keep the fibroids at bay and just reduce that red meat as well that I spoke about, right? And then there's information out there about chemicals and pesticides in your foods that can trigger fibroid growth. So they talk about doing more organic if possible, depending on where you live and what you have access to. Now, Bella Baby is asking, is it the same with cysts? Can cysts shrink with birth control? Now, that's a little different to the fibroids. Just even essentially what cysts are versus what fibroids are. Fibroids are very solid tumors, right? I just showed you some pictures of those. So fibroids of these very solid, this was surgery that I did. So fibroids of these very solid growths that do respond to estrogen hormone. So shrinking these is a little different to shrinking a cyst. Ovarian cysts tend to be just fluid-filled sacs, and that's what a cyst really is. You can have a cyst in any part of your body, and it's a fluid-filled sac. The ovarian function, ovulating, growing eggs and follicles, can be better managed by using the birth control, which suppresses ovulation. And by suppressing ovulation, then yes, you will definitely see a better response in most cases to cysts and cyst size and controlling cyst growth with the birth control pill than with the growth of fibroids, because that's why fibroids are so annoying, right? Now, the myomectomy surgery is an option to do if you would like to have children in the future or you want to keep your uterus for some other reason, but it's a surgery where you can keep your uterus. About 80 to 90% of women who have myomectomy will see an improvement or complete relief a lot of times from the symptoms that led up to them needing the surgery. So they usually see the symptoms are reduced or resolved in some cases. Myomectomy surgery can be done in a few ways, but again, it depends on the number of fibroids you have, the size of them, and the location. But most of the procedures will require you to be under general anesthesia. Blood loss is a risk, infection is a risk, and so forth. Now, I already said that the fibroids technically do not grow back after surgery, but you develop new ones. So studies do confirm that right now the numbers are saying about 1/3 or 33% of women who have a myomectomy will need some form of a repeat procedure in 5 years, right? So that's 5 years. That's the window where if you don't have a partner, you got to go on some dates, meet his mom, decide what you want to do, and then try to conceive and deliver within that 5-year window, because we do find that there is a recurrence of fibroids after that surgery 5 years later, or most procedures that are done for fibroids, there's an established 5-year window that we look at when we tend to see them causing a problem again. Doesn't that suck, right? So you grow new ones, and then when you grow these new ones, your symptoms return. And the symptoms again that I talked about initially, right? The heavy periods, which I would always measure that as more than 8. Periods are hard to measure, right? So more than 8 pads a day is excessive. So if you're doing more than 8 pads a day, you definitely want to make an appointment, get checked out, because that's a significantly heavy period. 8 soap pads a day is too much. Abnormal bleeding or spotting, especially in between your period, you need to get that tested, checked as well. So if you had fibroid surgery 3 years ago, 4 years ago, and your periods were improved after surgery, and here you are back with 8 pads per day or more, bleeding in between your periods, pelvic pain, pressure, pain with sex, painful crampy periods, vomiting with your periods, severe PMS, anemia, and of course that fupa that I talk about, the fatty bulgy area, is all reasons to get reevaluated that maybe, hey, my fibroids are back, because again there's a 5-year window, right? Now in terms of the cause, again, estrogen, right? So if you've had fibroid surgery and you still, let's say, have 20 more years of periods, then yeah, you're going to get fibroids returning again. If you've had fibroid surgery and you're in your mid to late 40s, you'll possibly, hopefully, enter your menopausal phase before those fibroids get a chance to be problematic again too. So that's very important when you're making a decision about what type of surgery and your expectations as to what the surgery is going to provide for you. So I said up to 80% of women have fibroids. That's a lot. If you have 10 of us in the room, 8 women will possibly have fibroids. In some populations it's 40%, some it's 50%. Afro-Caribbean women, 80% for sure. That's high numbers, right? But many women don't experience symptoms from their fibroids, or don't realize they have them until they've grown to a certain size and they could become problematic. And then in terms of the other issues, women with PCOS, where they have abnormal hormones and hair loss and facial hair growth and infertility and diabetes risk, will also be lumped into that 80% as well too. So fibroids and PCOS can exist in the same person as well, right? Avian is asking, myth or fact, I stopped perming my hair because I heard the chemicals in the hair perm may cause fibroids, and I had previous fibroid surgery. Beautiful. That's a great statement. And a couple studies, and I have to say a couple because we have a lot more work needed to be done, but there are studies that talk about perming of the hair. Now, the issue I have with these studies, and I also stopped perming many years ago as well too, because from the time I saw this information about perms and straightening your hair and fibroids, you know, you want to stop most of the things even if there's a chance that it could contribute to your fibroids returning. The studies that were done though, it's almost like if 80% of Black women get this thing, and then at some point, you know, maybe not as much now, most of those women were also perming their hair. It's almost that chicken or egg thing, or like, how do we really prove it's from the perm? And it would need to be reproduced more so in a laboratory, which has not been done to date. So I do question the validity, but I personally saw those studies and I don't perm my hair, because if there's even an inkling of a chance that this can cause or regrowth or recurrence of fibroids, then yeah, you know, we'll figure out our hair some other way. And it does add to the fact that, you know, perming of the hair is something Black women do for the most part, with those chemicals and those lye to straighten the hair. So it is valid to look at that as one of the reasons when you're looking at one population being affected by this, right? So that was a good point. We have another comment or question here. Does having hypothyroidism, which is elevated thyroid function, affect the growth rate or even cause fibroids? So thyroid disease doesn't cause fibroids. However, women with, hey, Dr. Bradford, you can jump on in anytime. You know what? I will text you. And we will do a maybe question answer live because you know all the stuff. You can correct me if I say anything wrong as well. But in terms of the question with regards to, let me go back to the question. You asked about the thyroid. Your symptoms from the fibroids could be worsened by thyroid disease. So I hope I answered you properly there. The thyroid dysfunction won't cause fibroids, but your bleeding may be worse. Your bleeding may be erratic from having thyroid disease, right? Thanks, Dr. Braff. I will definitely text you. I can't believe your hair being bored by me. So if you have fibroids and you've had fibroid surgery, you still need to be monitored over a time. That's the other thing that I see a lot. I had surgery in, let's say, 2015, and I didn't go back to the doctor. My symptoms got better. I haven't been scanned. I haven't had an ultrasound. I haven't been seen. You should be still monitored because, you know, just you're genetically programmed to make these things, and they'll come back as long as you're having periods. The severity and the number may vary, and it may not be as bad as before surgery, but you still have to continue to be monitored. And often there's no need to take any immediate action. If you want to keep track of them, periodic pelvic exams, just stick to a yearly checkup. An ultrasound might be recommended, just to follow those as well too. And then follow and tracking your symptoms and what you're experiencing, tracking anemia, infertility issues. Remember, I would have said 5 years after surgery, we probably need to do something again about fibroids. So within that 5-year span, even if you don't have your specific pregnancy plan or partner, you still want to track those as well too. Now we have 2 comments here. Avi again says, do most doctors look at your family history when it comes to fibroids? I can't speak for most, but I would assume so. It is something to mention when you ask about your family history. We probably could do a better job in general in sort of tracking our patient's family history. For me, I look at the statistics and they already say 8 out of 10. So if I see 10 women in the office tomorrow, I'll probably need to know that 8 of them had a mother or sister with fibroids, because there is a genetic link and it does run in families, right? So that was a good question. And then, oh my gosh, hi, how are you? Flour Bag Baking Company. Is it true that chasteberry has been tested and proven to balance hormones that cause fibroids? So let me just dissect that question a bit. The hormone that's thought to cause fibroids is estrogen, right? Chasteberry, which is great for balancing hormones, and it's marketed as Vitex, and it's a great product. I talk about it all the time with regards to PCOS. It tends more so to balance or work on the LH hormone or luteinizing hormone, which affects the male hormones and androgens and testosterone. So it tends to balance those more than it would balance estrogen in our system. Like, we are estrogen factories, right? And balancing estrogen from a holistic standpoint comes more from exercising and managing your body fat percentage, which you guys have heard me talk about already quite a few times. I had Carver on here talking fitness, and managing estrogen excess really is closely linked to nutrition, avoiding highly processed foods and high fat foods, and exercising, working out to keep your body fat percentage in check, because pretty much that's where we store estrogen. Chasteberry, I never knock it. I talk about it all the time. I actually did a whole live on it at one point, and maybe I'll do another one soon. But it doesn't have a direct link to the fibroid issue, unfortunately, but it definitely would benefit you in many other ways in terms of balancing LH and androgen excess, which can happen in the same person with fibroids and also with PCOS as well too. Excellent question, guys. So I was talking about myomectomy, right? So again, there's risk with surgery. So when making your decisions, this is what you also have to consider. There's risk of infection, bleeding, myomectomy. There's a great amount of blood loss with myomectomies, depending on the number of fibroids and the length of surgery. So a lot of times we would need to make sure that you have blood available in advance before having a myomectomy done. And then additional risk of surgery down the line could affect future pregnancies. This is the need for C-section, the difficulty conceiving sometimes after having a very extensive myomectomy as well too needs to be considered, right? And I have another, this is what I want to show. I hope you guys aren't too grossed out by this one. It's not like bloody, but it's kind of like the real picture of a uterus that was taken out at the time of a hysterectomy, which is different to myomectomy. Hysterectomy, the uterus is removed in its entirety. So it's a lot less bleeding and blood loss, but once it's removed, it also means you'll never, ever, ever get uterine fibroids back again because the uterus is out. However, you can never carry a pregnancy again. And this image here is just showing a uterus that has, I counted 1, 2, maybe 4 fibroids, a few large ones, a small one. But you kind of get a sense from this picture how it's really just the muscle of the womb that's grown into this sort of very firm, rubbery, they're quite rubbery and firm ball, literal ball that grows in the uterus, right? The exact cause of these fibroids is not known, except for we know that there's a link to estrogen. And we know this because during pregnancy, these fibroids respond even more to the hormones in pregnancy and they grow with pregnancy. We also know that when a woman is no longer ovulating, no longer having regular periods, the fibroids tend to shrink. So fibroids usually develop during a woman's reproductive years, can be found in girls as young as 16, which really sucks. Luckily, that's not common, all the way up to age 50. On average, fibroids become problematic in the mid to late 20s to mid 30s to 40s. But the age range in general, 16 to 50, when a woman's estrogen levels are at their highest. They tend to shrink when the estrogen levels drop, such as after menopause or when any situation that stops your periods, except for pregnancy, right? We have a question here from Tisha. Hi, Ms. Wills. She's asking, is it a must to use compression stockings after myomectomy? Absolutely. I don't know if Dr. Bradford is still in there, but yes, most surgeons would insist on the compression stockings because during surgery, your circulation is in a state of stasis and the risk of forming blood clots on the operating table, and even in the times when you're not as able to be ambulatory and move around as much, the compression stockings are absolutely a great tool to reduce your risk of forming blood clots and to kind of keep the circulation going around the time of surgery. Now, Anik, hi, what is the estimated recovery time after surgery? So after surgery, which is the myomectomy, especially the open myomectomy, which is typically done when these fibroids are really big, and several of them, the typical recovery time is about 6 weeks on average. I usually say 6 to 8 weeks before you can resume full work and full activities and return to regular exercise routines and sexual activity as well. Okay. Yes, agreed, Miss. Fibroids are quite out. They're annoying and out of timing. I like that. Okay, are there any options to help prevent regrowth of fibroids besides birth control pills? So I am going to get into that for sure. Everyone's agreeing with you about them being out of time, and I agree too. Now I'm going to talk about the options to reduce the recurrence, but there's no prevention, which is kind of crappy, right? So there are options to kind of try to reduce them, but the key is really following them and monitoring for the recurrence so you don't get caught off guard, and you can try to manage them when they're less and smaller. And then again, understanding the 5-year window. Fibroid surgery happened here. Within 5 years, if I want my 2.5 kids, I should be working on them within that time frame as well too. Now, the normal uterus size is the size of about a lemon, right? Which is about 8 centimeters. We always talk in fruits and veggies, by the way, in gynecology. There isn't a definitive size of fibroids because that would need surgery because, again, the location and the number of them. So, for instance, you can have a fibroid the size of a marble that's in the uterine cavity that would cause you to hemorrhage and bleed more than a fibroid that's located outside. But the fibroids that are usually the size of a grapefruit or larger will cause pelvic pressure and pain with sex and difficulty peeing, and your tummy looks larger and so forth. Now, There's also laparoscopic myomectomy, which I guess asks about a lot too. But typically, most experts agree that laparoscopy for fibroids does not make sense if the fibroid is larger than, like, I don't know, 3-4 inches. If it's larger than 3-4 inches, if it's several of them, then it's actually safer and more beneficial to do open surgery. Right? These are just points about myomectomy to know that are important as well too. Hysteroscopic myomectomy is when we go with a light source and a camera and instruments into the cavity to remove a small fibroid that's in the cavity without having to cut, and it's done through the vagina, and you go home the same day, and the recovery time is like 3 to 4 days, less than a week. And those are the very small ones. But larger than that, typically we go through that bikini cut. And sometimes in the very large ones, watermelon size, we would make it a vertical incision up and down the tummy, right? So the method will always depend. So you can't compare your story to your girlfriends or anyone on the internet, because the method for surgery will always depend on the size and the number. Now let's talk a little more about these growing back or regrowth of these fibroids. Now, younger women, so you're let's say you're 22, 23, with multiple fibroids are at greater risk after surgery of getting them recurring again. Of course, she's had a lot to begin with, so she's probably capable of growing many more. And then age at the time of surgery as well too allows a lot more times with regular menstrual periods, exposure to estrogen for the fibroids to reoccur. So younger women are more at risk than someone who's closer to menopause with fewer fibroids. So I think this was the Mayo Clinic came up with some data as well too to better counsel, because a lot of information is lacking, right? So they found that if 4 or less fibroids were present at the time of surgery, then within the 5 years after surgery, the risk of getting new fibroids was as low as 10%. So if 4 or less was present, then that risk is as low as 10% for fibroids recurring. If there were more than 4 fibroids present at the time of the myomectomy, the chance of regrowth is more than doubled. So it's about 1 in 5 women who have 4 fibroids or more removed will end up having a recurrence of fibroids as well too. And again, remember that we never really know until the time of the actual fibroid surgery exactly how many fibroids are there and how many are going to be removed. But what we do know is the magic number seems to be, according to the Mayo Clinic, 4. 4 or less, you have about only a 10% risk of them recurring. More than that, then it can happen. Now, if they do reoccur, it's still the same rules that apply. The number of fibroids, the location of the fibroids, and your symptoms would really address what you want to do, because not everyone wants, most people rather, let me correct that, may not want to go back for more surgery. So again, the situation may be monitored, or what we call conservative management. Just observe these fibroids. How bad are your symptoms? This is when the pill may come in as an option to suppress symptoms and improve quality of life, knowing that the pill does not shrink or remove fibroids, but it can improve symptoms. But let's say you want to conceive and you can't be on the pill, then that's when you have to consider alternative options. Some women may need repeat myomectomy after that 5-year span. If they still have not achieved pregnancy and the fibroids are problematic, it may make sense to go back and do a repeat myomectomy. Not the most fun time for her to go back in for more surgery. The risk is higher, scar tissue, adhesions, risk of bleeding, and then of course the risk of ending up with an unplanned or unintended hysterectomy when we go back for that second myomectomy, because we may need to do a hysterectomy to save her life. So the decision to make that second fibroid surgery happen is often quite multi-layered, because again, symptoms, what my goals are, and what if I don't want any more children, or I don't want any, then that repeat surgery might be better be done as a hysterectomy to remove the uterus and reduce the risk for me during surgery. Another option is the uterine artery embolization procedure. I think I found out we have a question. How is a myomectomy done for someone who has hypothyroidism managed especially when cardiac arrest under general anesthesia is possible. So we don't see it as the hypothyroidism or overactive thyroid. We don't see it as a reason, as an additional risk if your thyroid function is controlled. So if you're on your medications and your levels are fine, and most times we screen thyroid function prior to surgery for that exact concern, cardiac function, anesthesia risk, but hypothyroidism is not a reason not to address the thyroids. A lot of times we must, right? So controlling thyroid function in conjunction with your general practitioner or your endocrinologist is important prior to any surgery, not just fibroid surgery, right? So it's not a factor that we use as a barrier. Okay, so Tisha says she's not going back, and I believe you. I know, going back for more surgery. So this is when some women may consider uterine artery embolization, which is depicted here. It's also known as UFE, or uterine fibroid embolization, or uterine artery embolization. Now, this procedure is not surgery. It's not done by a surgeon. It's not done by a gynecologist. It's done by a specialist radiologist called an interventional radiologist. And it involves introducing a very slim catheter into the artery. They access it either from a blood vessel in the groin area. Even more updated techniques, they just go through a vessel in your upper arm, but there's no bikini scar or cutting. This procedure could be considered by someone who has a recurrence of their fibroids. So even if you've never had fibroid surgery and you're sort of delaying or deferring the option for surgery, or you don't necessarily feel comfortable doing surgery, this is less invasive and it is an option. The problem with this is the fibroids are not removed. They do remain, but the symptoms do decrease, improve dramatically for some women. When they access the blood supply to the fibroid, they inject or release these very tiny microspheres or plastic granules that they use. I say the word plastic loosely because it's not plastic like plastic that we're surrounded by. Obviously, this is medical grade stuff that is tolerated by the body. The embolization technique is not new. Embolization is used for many varying organs in the body. So this radiologist would be the radiologist that might embolize the spleen or liver after a gunshot, or embolize something in the heart, embolize kidneys. They can embolize things. And embolization just basically means that they're cutting off the blood supply. So they use these little granules that plug the blood vessels and essentially starves the fibroids. So in the office, when I talk about this, I usually use my fist and I'm like, this is the uterus or the fibroid. And if you tie a tourniquet and you basically cut my blood supply off, my fist is going to start getting smaller and it's going to what we call atrophy. It's going to be losing its blood supply and it's going to shrink, right? From lack of blood supply. So essentially starving the blood supply. This procedure typically takes about 2 hours. It usually requires less anesthesia. Sometimes they may not even need general anesthesia. They may do conscious sedation, lighter anesthesia, and so forth. It usually requires at least a one-night stay or a day stay in the hospital for pain control, because my hand is shrinking, the fibroid, right, starving. That can be a source of cramps and pain that may require medications prior to being released home. This procedure has a shorter recovery period, right? There's no scar, there's no wound, you didn't lose, a liter of blood and all of these things. There was very minimal blood loss as a result. So within 1 to 2 weeks, but the larger the fibroid is that's being embolized, the more pain that's going to exist. So sometimes I may tell someone that's a cute procedure, but not for you. If your fibroid is the size of a watermelon and the watermelon is shrinking all at once, yeah, you didn't get a cut. Yeah, you didn't get excessive bleeding and so forth, but it's pretty painful. And then on top of that, you may not see enough of a shrinkage with a fibroid that's too large that really needed surgery. The fibroids are estimated to shrink up to 60% in size, which is pretty impressive. And for the person who is experiencing symptoms from fibroids, once this fibroid is reduced by 60%, they are going to note that their symptoms are much improved. Right? So I saw some comments on here. So Shana is saying, is it possible that the particles could cause harm? So I think I'm going to get into that briefly. Yeah, it's right here. Exactly. You're right on point with that question. The rate, so I'm going to just finish this about the UFE because I do answer that question about the harm of these particles. The rate of recurrence of fibroids after this procedure is still uncertain because it's relatively new procedure. I don't think it's relatively new. In my world, I've seen this in training, but still relatively new compared to the surgical options. So data still has to be continued to be collected. Patients are usually advised, they were advised in the past, don't conceive or get pregnant after this procedure because they weren't certain what would happen with pregnancies. But now more and more and more, we're seeing more successful pregnancies after embolization, but it still depends on number of fibroids, location of fibroids. So fibroids continue to be a very unique, your story. Because your story may not line up with someone else's. And I still stick to the 5-year, just like after myomectomy, 5-year window where we may see fibroids re-establish blood supply and become problematic as well. And then the thinking after getting pregnant after the procedure is, hey, you've affected or disturbed the blood flow to the womb. Is this going to cause low birth weight, miscarriage risk, placenta issues? We're not sure, but we do know even with fibroid surgery, even when we remove, let's say, the 1920 fibroid removal case, we may have issues later with the placenta attaching properly and so forth. So the risks are there regardless. But regards to the particles, there is, especially if a lot of areas are embolized in the uterus, it is possible that these particles that are released can actually impact ovarian function. That's why the ovaries in this picture here. The ovaries have their own separate blood supply, but they do rely on some blood supply coming from the side of the uterus. And when we've embolized, sometimes this can affect the ovarian function in about 5 to 10% of women who get embolized. This embolization procedure in a slightly older woman in her 40s may find that her periods become so light, so less flow and lighter, and these fibroids and so forth, that she may actually find decreased ovarian function as the cause for that as well too. And that's just in about 5 to 10% of people, right? Next question we have here, or comment. Oh, you guys are on fire tonight. Let's see, where am I? Okay, so that was about the particles. And then I need to get my fibroids under control. Too many odds are stacked against me. I agree. But knowledge is power, right? Knowledge is power. And then Anika is saying to book an appointment with us. Okay, great. Now, the next thing I'm going to really talk about is, let me just scroll a little bit here because I touched on a few things. The other reasons to consider surgery. So I had fibroid surgery maybe 5 years back, and the fibroids are back. There is a rare situation, maybe 1 in 10,000 is the number that we look at, that a fibroid can transform or develop into what we call a sarcoma. A sarcoma is a very aggressive cancer, very rare cancer. So sometimes if we see a fibroid that's just growing exponentially fast, it's just really aggressive, we may counsel you, hey, that embolization is not for you. Let's get this fibroid out of here because it's tripling in size within months. Very aggressive growth, which is again very rare, 1 in 10,000. But I know that's important to mention as well because most fibroids will not become cancer, but sarcoma is 1 in 10,000 cases, right? The next comment from Shana is, the broad ligament contains a lot of arteries. Yep, that's true. Do you think it's risky to embolize a fibroid located there? So that decision for a broad ligament fibroid to be embolized really has to be made with the radiologist doing the procedure, to be honest. Some of them work and train and breathe and live fibroids, right? So it depends on their comfort, and that's in general with most things, right? Even if it's toe surgery, it depends on the comfort of the person doing the procedure. The broad ligament is fairly tricky, and that's a great point. And me being a gynae, a surgeon, I'd say do surgery for it, to be honest. But surgery isn't always the best scenario. And anywhere that the fibroid is located, if the embolization can access the direct blood supply, then it can be done. the way that they do procedures, it allows them to traverse these arteries quite specifically. So the risk is there, of course. It's a tricky area to have fibroids. It's a tricky area for surgery as well, too, because doing surgery in a broad ligament might end up with a hysterectomy, which means no pregnancy in the future if that was the goal. So embolizing still is a good option, but it depends on the comfort of the person doing the procedure, and you're trusting them to know what they're doing, because they do use imaging and fluoroscopy to follow the veins and the venous and the arteries. So they do really track these tiny vessels fairly well. Okay, so I hope I answered your question there. All right, so next, in terms of, okay, so I had fibroid surgery, and my fibroid, we haven't, okay, so you're saying the surgeon was scared and advised not to remove it. I figured I needed a new surgeon, but that's when I got introduced to UFE. Yes. So again, and there's some excellent interventional radiologists that have like been published and written papers about fibroid embolization, and they're probably very comfortable with a broad ligament fibroid. So again, that's the best approach there. Now, fibroid has regrown. Embolization is one option. Another option is hormonal treatments, which is to answer the earlier question about the pill. Hormonal treatments have relatively little effect on fibroids themselves, right? In fact, birth control pills can sometimes make them grow. Right? They can. And one exception, they can make them grow. Estrogen is in the pill. So the pill is controlling your symptoms, your periods are better, but it's the fibroid sneakily growing on the back end there. Sometimes that does happen, and it sucks. But they can make them grow. One exception seems to be the Mirena IUD. So I had my fibroid surgery, a few of them are back, my symptoms are kind of annoying me. I want to fix them, but I'm not looking at surgery, and I don't really need to do embolization per se. But I can consider Mirena IUD, right? The Mirena is the IUD that contains progesterone. It doesn't have any estrogen hormone on it. It's a T-shaped birth control device that sits in the cavity of the uterus, and it really substantially reduces menstrual flow. Now, your first 3 to 6 months with the IUD can be a bit iffy because you do have spotting and irregular bleeding and cramping. It can also cause acne and bloating. I wish there was something with no side effects, but yes, it does have side effects. But in some studies, more recently, they're showing that there is some slight reduction in fibroid size while you're also enjoying the benefit of managing your symptoms when you have a Mirena IUD. And once in place, the Mirena IUD can be in place and effective for up to 5 years. Some people say up to 7, but the manufacturer says 5 years. And in those 5 years, you can see some improved quality of life. You can see reduced symptoms, and also you can, possibly somewhat decrease the size of your fibroids as well too. Okay, Tisha is asking, how soon after myomectomy can you do Mirena? I would say within about 2 to 3 months after, at least a couple period cycles later, you can do a Mirena. And again, with the Mirena, you will not be getting pregnant. It's birth control, but you'd be benefiting from, improved period symptoms while you heal. That's not a bad idea, right? The time between surgery would be decided also based on how surgery went, complications during surgery. Sometimes we do the pill after myomectomy. If the cavity of the uterus had a lot of surgical damage and we wanted to heal, we might do the pill and then transition to an IUD. So it's, again, case by case. Right? But because fibroids are mostly dependent on estrogen to stimulate their growth, we really expect them to grow until menopause, and that's why it's important to know if you've had fibroid surgery, they can grow back. Hormonal therapy, the pill doesn't do anything really except ameliorate your symptoms. In some cases, the pill can trigger growth, so we be careful there. The Mirena is an option as well too. Then there is Lupron, which can result in a 30 to 60% decrease in the size of the fibroid. Lupron is what we call a GnRH agonist, which acts on the pituitary brain, in our brain, gland in the brain, and it shuts off ovarian function. It puts you into medical menopause. It is very temporary. You can really only safely use it for a few months. I believe the maximum is up to 6 months of use. And then when you stop it, the symptoms return. And we usually use it just to make surgery a bit easier. But Lupron has side effects. Oh, there's Avi right on time. Yes, the side effects of Lupron are quite unbearable for most of us because you go into menopause, and it's quite intense because it's the hot flashes, mood swings, irritability, bone pain, vaginal dryness, decreased libido, on and on. But so its best role is to shrink fibroids prior to surgery, but it's not a long-term option, right? So if you have a regrowth, either we're considering more surgery, an embolization, or we're managing our symptoms as best as we can. All right, guys, so how do we do tonight with these pesky, annoying fibroids that are out of timing? I like that so much because they are. I believe I addressed the questions, and you guys asked some really great questions. Zoladex is the same. Zoladex is the same. The hot flashes, exactly. And it's a lot more intense than when you go into your natural menopause, which you will. But when you go into natural menopause, it's over a course of 2 to 3 years. With these medications, it's quite instant. Same as with hysterectomy, where the ovaries are removed, you have those symptoms quite instantly as well, too. So that's it in a nutshell. I could go on about fibroids, by the way, for like 2 more hours. But these lives are going to keep coming, and Dr. Bradford offered to do a live. So maybe you guys will, here's what I'll do. I'll ask the public what topic you'd like to hear Dr. Bradford and myself speak about, and I'll probably try to coordinate a live with him. And maybe I'll do a post and you guys could comment, and we'll see which of you guys vote for the most popular topic, and we'll have a live together. He's another obstetrician gynecologist here in Trinidad with me, right? So you're so welcome. Thank you for responding. Shana said this was excellent, so informative. Thank you for your time. Oh, my pleasure. Thank you. These options don't sound very comforting at all. I know we need more research, and maybe not my generation, maybe you guys, maybe the generation next, but we'll get more research done and we'll get to the bottom of this. Tisha saying, thanks, Doc. I really appreciate this session. Recently had my myomectomy. I've been having some anxiety over this exact topic. Again, if you plan for pregnancy, there's a little bit of a clock ticking here, and I don't care if you're 25 and the world says you're too young. You're not too young if you have fibroids. Get those babies out the way because they do return and they do recur as well too, right? You guys are so welcome. Fibroids suck. We will definitely do a fibroids part 2. And thank you, Stacy. Says excellent info. Thanks, guys. I'm going to post this up, and there's always more to talk about because I have so much more to say. What I'm going to probably do, because the live I did last year, I did 2 parts on fibroids. I will probably do a part 2 because I think it's important for you guys to learn more about plastics and fibroids and pesticides and fibroids and the ways that we can adjust our day-to-day exposure to these chemicals environmentally that cause fibroids. So I'm going to close this session off, but I think I'll do that as a part 2. It's easy for me. All the information is locked in here. I'm going to talk about how they were able to grow fibroids in lab rats, right? They were able to grow them in lab rats. So I'm going to talk about that a bit more, right? A new topic, ovarian rejuvenation. Right. Thank you, guys, and everyone have a great rest of the week and a great weekend, and thank you for your time. Thank you, and good night. Good night.